you, and then we will.
Actually, I can speak and introduce you, and then you can introduce.
Start. We can live now.
Hi, friends. Welcome to yet another episode of Innovation in Hematology, and this time it's in Innovations in Genomics. We have got two stalwarts, Dr. Srinidhi from India and Dr. Keyur Patel from US, spending their past 2 decades or 2.5, 3 decades into the field of genomics and giving us newer pathways and newer genomic data to act upon and probably increase the survival from there on. It is a fascinating journey for all of us at Fortis Institute of Blood Disorder, where Dr. Srinidhi has established the GenX machine, which has been able to give the genomic data in 3 days, and which actually has brought in the precision medicine for the first time in AML. So now if you have a TP53 mutation, we know that in a young patient also giving 7+3 might not be a good idea, and they can always directly go on decitabine, venetoclax, and so on and so forth. So the understanding of the genomic data within 3 weeks, where we were just waiting, and versus 3 days, is an eye-opener to all of us. Today, in next 35-40 minutes, we are going to dwell upon the genomics of AML. And believe me, if you see through the eyes of a clinician, it has created a chaos to the next order into my mind. Because how? Because it is giving, as it's throwing more data, it is also telling us to ask those questions: who chooses whom? Who will choose which mutation will choose you? Or how body decides to have a co-mutations with FLT3, with IDH1? Which kind of FLT3? Which kind of a TP53? Why? What kind of a SEPA? What kind of a RB mutation has led to the SEPA mutation? So I think it is more relevant for all of us to understand that genomic data which comes through a throughput, it's not only the machine which gives you, and it's just not a piece of paper where you act upon by saying, oh, transplant or no transplant. Dr. Srinidhi has brought in a new dimension to of understanding the mutation in the context of AML and how to monitor it thereafter. And last parting thought is NRAS new TP53 for hematologists, because NRAS doesn't just go away from a chemotherapy. Flumel, Flubu, Flutrio, Fluthiotepa, NRAS is there at 2 years, and that might be the cause for your relapses. So, friends, stay hooked on for next 30 minutes, 35 minutes. Continue asking your questions on the chat box. This is not, I'm sure we will have more of such sessions, and Dr. Keyur Patel will oblige us, because this 35 minutes cannot justify his past 3 decades of hard work into this area. And with this, I give it back to Dr. Srinidhi, who has been an integral part and established Fortis Institute of Genomics painstakingly for past 3-4 months. Now we have GenX machine, we have got DDPCR, we have got S5 Plus, and soon we are going to have a mass spectrometer for myeloma patients. So Dr. Srinidhi, over to you, and looking forward for these 35 minutes, 40 minutes of a wonderful interaction and understanding which can enlighten us for making the future brighter for our patients. Over to Dr. Srinidhi.
Thank you so much, sir. And it is all because of you and the leadership at Fortis that we have been able to do this. So I'll just share my screen, and I don't want to waste time because I want Dr. Keyur Patel to speak more than I do. So, I welcome everybody to Innovations in Hematology, which is our scheduled webinar series at Fortis Institute of Blood Disorders, and we take pride in it that we bring something different all the time. And today's topic is evolving trends in AML genomic testing. And I think Dr. Keyur Patel needs no introduction at all. We all read all his papers and we know everything that what he does and his state-of-the-art lab. He is the Director of Molecular Diagnostics Lab, Precision Oncology Decision Support, Molecular Genetic Pathology Fellowship Program at the famous MD Anderson Cancer Center, Houston, Texas. And he needs actually no introduction. His profile is all full of lots and lots of colors, but what I want to highlight is that he is our own Indian, and it gives us a lot of pride that, he's done such remarkable job that he has so many national and international publications to his credit. He's renowned to know practically everything in AML genomics, and that is why I'm not going to waste too much time and I'm going to hand over the mic to him. But before I just hand over the mic to him, I just want to give a little brief overview of what we do in our 4 months old lab. What is our algorithm at Fortis? Whenever we have a suspected acute leuk, the patient is subjected to a bone marrow aspiration, biopsy, a flow cytometry, and an NGS in the same draw. And we are very thankful to our hematopathology lab headed by Dr. Asta that we get the aspiration and flow cytometry on the same day. And practically, if the sample comes in the morning, we get it in the evening maximum. And the NGS, we get it in 3 ± 2 days because of the Genexus machine. And we've done close to 200 cases now with a median TAR of close to 4 days. And we take pride in saying that we've not repeated anything, we've not had any rejections, and we've been able to find some novel variants, although very, very few. But then, we are just 4 months old into this right now. So over to you, Dr. Cure. And this is our entire team, which is a multidisciplinary hematology team with adult, pediatric hematologists. We have hematopathologists, we have geneticists, we have infectious disease specialists, we have critical care people, we have dietitians, we have nurse practitioners, and everybody works day in and day out to take care of all the patients who come to Fortis. So I won't waste too much time, and I'll ask you to please share your screen. And we are really, really happy to have you.
And thank you, Dr. Sinidhi, and thank you, Dr. Rahul, for that kind introduction and the opportunity to share some of my thoughts and previous work with the group here. And I'd like to congratulate you all for this wonderful achievement. This is amazing and so rewarding to see that there is an Institute for Blood Disorder, which is state of the art, and also there is a very nice interdisciplinary teamwork happening there, which is really the key to success. We can no longer care for these patients in isolation, and interdisciplinary teamwork is really the key to success. So my congratulations to all. Wish you the best for continued success. Your numbers look amazing for a 4-month-old lab. And please consider me your partner as you move forward in your journey. I'd be really happy to get on a call, discuss, and be part of your team. Thank you. So with that, let me share my screen here. Hopefully you can see the screen well. This is a view of the wonderful MD Anderson Cancer Center, where I've been fortunate to spend last 15 years of my journey here. My office is actually located in one of the buildings that you see in the back here, on the right-hand side, and I've been fortunate to take care of patients and be part of a wonderful team that does some amazing work. So with that, let me see if I can get going. Okay. So my overview will talk a little bit about the genomic discoveries. We'll go into the clinical applications of genomics. We'll talk more about the modern genomic assays, and then we'll end with the future directions. So we all have seen this evolution, or rather revolution, in the genomic discoveries in leukemia. I personally look at it as two different phases. The first phase really started out with a lot of the discoveries at the chromosomal level, which really meant to identify translocations. And again, these are tracking along the lines of what technologies we had. So we had technologies to look at chromosomes back before 2000, and a lot of these discoveries are actually translocations. Once the next generation sequencing came about, we started discovering more and more gene level mutations. And some of you may know that NPM1 actually was outcome of an immunohistochemistry study, so it did play a role. So it just goes to show how important it is. And being both a hematopathologist and a molecular diagnostician, I think this journey has been very rewarding to see how we've been unlocking the secrets of this very deadly disease, and how we are fighting back now with therapies and tools. But what we now are facing with this is that we have a plethora of information about the biology of the disease. And the challenge for us is how do you translate this into routine clinical testing? And that's the challenge that we face in the clinical molecular diagnostics laboratory. My talk is going to focus more on the clinical applications rather than research and discovery, just so that we can understand where we are going from here and what really is the task ahead of us. Before we get into the actual laboratory testing, I think there are some very important pieces of information that we need to review. And one of them is really the TCGA effort that paved the way for us to understand the AML genomics better. From those TCA papers, what we learned, and if you can see my mouse pointer here on the upper left-hand side, the tumor mutation burden, AML really is a disorder where there is, possibly one of the lowest tumor mutation burden that's out there as compared to some of the other solid tumor. So that meant that if you're only looking for mutations, you won't find a huge number and as compared to some of the other tumors, but we can work with that. When you look at further in these mutations, you can see that the mutations are actually categorized into different genes. So we are understanding a whole lot about the fusions, the mutations, and so forth, and how their co-mutation patterns are evolving. Going beyond the mutations, in the middle portion of the pen, you can see that the TCGA effort also identified what happens to the next level after the DNA, which is the RNA. There are different RNA expression patterns. We really haven't unlocked these mutate expression pattern signatures yet. That's the next frontier. Similarly, the DNA can be methylated, and there is also definitely different patterns, as you can see, just purely looking at this heat map. So there's a lot to uncover here. So we are somewhat, to some extent, scratching the surface here of this mountain that lies under the water, the tip of the iceberg, in terms of what we can do to unlock the secrets and then address therapeutic challenges. What we also discovered through this TCGA effort and subsequent efforts is there are multiple different gene fusions that can arise. Again, these are important for how we develop the diagnostic and therapeutic strategies. And more importantly, we know that AML is not a static disorder. There are multiple types of AML. We have a de novo AML, we have secondary AML, we have therapy-related secondary myeloid neoplasms. So there are multiple pathways along which AML can evolve. And these types of dynamic studies have really shown us different paths that the AML can take. And so this is really, again, key to our understanding and personalizing care for our patients. When we go a little bit deeper, just purely looking at the mutation spectrum on the translocation, so staying focused on those two key areas, what we see is that the AML can be divided, or the genomic alterations in AML can be divided by the mutation frequency, NPM1 being the most common, followed by some of the other ones where chromatin spliceosomes and others. There is a large number of translocations that you can see on the upper right-hand side. So from 12 o'clock to about 4 o'clock position here, these are all defined by different translocations. When you go a little further, although the translocation is the defining event, they may have cooperating mutations such as ITD mutations, so and so forth. And to Dr. Rahul's point, you can see that KRAS, NRAS, and others are frequent in many of these conditions. So although these mutations may or may not be the primary drivers, but they are the culprits who can actually lead to a more aggressive phenotype, can lead to a resistance, can lead to a relapse. So there's still a lot to learn, because a lot of these studies are done at the bulk DNA sequencing level. We are now performing more single cell sequencing, so to understand this a little bit more. When you go a little deeper on the lower left-hand side, what you can see is that each of these biomarkers can now be assigned some sort of a clinical application. So starting from the diagnosis, which is generally the first steps, and just using an example of NPM1, which is the most common, one of the most common mutations or genomic alterations, we now have WHO and ICC classification categories that define the AML with NPM1 mutation. So you need that at diagnosis. We know that these mutations, along with some co-mutation pattern, can have a prognostic impact, favorable, less favorable, so forth, based on the co-mutation. So they can also provide prognostic information. We now have menin inhibitor therapies and such, which can also now provide a predictive information, meaning can you treat patients with certain drugs. Similarly, for IDH1 and IDH2, we have inhibitors. So you can see that purely from the discovery, now these biomarkers are rapidly translating into clinical applications where knowing their status at different points in time can provide you very important information. And more, once now that we have addressed the baseline genomic profiling and come up with therapies, what's becoming very important is the minimal residual disease monitoring or measurable residual disease monitoring to make sure that we eradicate the leukemia once and for all. So you can, and this is just one example, you can look at every single biomarker in this lens and then see where you can use it for baseline versus follow-up. And this just opens up a whole new field, an area of investigation, and the need for us to understand a little better. What this has translated this into is, again, as I mentioned, the diagnostic applications. The applications, and as you can see, we had a revised WHO classification in 2017, and unprecedentedly now, within the 4 years or less than 5 years of that fourth classification, we have now fifth classification, and not only one, but two, both recognizing the need for integrating genomics into the classification. There are experts on the audience here on this topic, so I won't go into too much details, but you can just see how we had a limited number of genomically identified classifications in 2017 and fewer than that in 2008. Now there is a lot more, and there is a lot more entities which are also proposed. So again, this is refining how we understand these diseases and how we classify them. Not only the classification requires the understanding of these mutations, there is also algorithms. So this is just showing one of those ELN algorithms to show that we can apply this approach in terms of how we classify different AML. And you can see that it relies on having genetic abnormalities, or P53 mutation, or mutations in a number of MDS-related genes, and also understanding the karyotype. And then last but not the least, there's also definite recognition for germline predisposition. So this really provides a framework for how we approach diagnosis, how we come up with these diagnostic classifications, which has further bearing onto treatment strategies that we use for this patient. What this indicates is that at baseline, even we do need all of this information to provide a more personalized diagnosis for the patient and risk stratification and therapeutic approaches. So for AML in particular, how does the clinical genomic testing or application look like? So I look at it as the 2 or 3 different phases, actually, where the initial workup where the tumor burden is high. The goal is to identify a diagnostic, prognostic, and treatment selection markers through comprehensive assessment. Once this is done, the follow-up monitoring, where the tumor percentage is low, our goal are to actually perform to see if what the response is there an MRD, is a new resistance is emerging, and if the patients undergo stem cell transplant, how successful is the transplant and how MRD is evolving. And this is achieved through more targeted and sensitive assessment than more comprehensive and less sensitive assessment. Unfortunately, many of these patients would relapse or progress or transform. And at that point, the goals reverse, and we again look for more clonal evaluation, resistance, and new targets. So it's very important that the treatment it's very important to factor this in when we come up with diagnostic strategies so that we can provide the appropriate testing for the appropriate time point. So what does the AML care look like from in 2024? So we do need a comprehensive genomic testing assessment, and yet it needs to be flexible. We have now seen a trend in the conventional morphology first approach, where we would look at the smears, the biopsy, touch prep, MPO stain, and others, and sometimes even flow, and say, now we need this molecular testing. I think having a GeneXus equipment there with a 3-day turnaround time at Fortis again really highlights this fact that you need to trigger both in parallel, and that's becoming a practice in many academic medical centers. across the globe, where both morphologic assessment as well as specialty testing, including molecular genetics and flow cytometry, is triggered at the same time. So the assays that we need in characteristics that we need in an ideal clinical genomic assay is really we need it to be comprehensive. We need to cover multiple genomic alterations such as SNVs, indels, copy neutral, LOH, and fusions. For it to work and be sustainable and be affordable, it needs to be cost effective. That's one of the major challenges that always comes up as the technology evolves and it becomes more powerful. The cost also goes up. It does need to have a reasonable turnaround time for it to be useful clinically. And we can also desire it to have a controllable sensitivity, meaning what we need for diagnosis is different than what we need for follow-up monitoring. So this is easier said than done, because this really creates a lot of challenges for the laboratories and healthcare operations. But again, this is where innovation, teamwork, coordination comes into picture. For us, the journey has been very rewarding and very challenging at the same time. This slide highlights the different genetic alterations and their detection methods. Before the days of NGS in around 2012 or late 2011, our laboratory maintained several different platforms depending on the type of different alterations. So we saw in earlier slides that our molecular genetic workup requires identification of mutations, translocations, amplifications, and so forth. Before the days of NGS, there was no single platform that could do all of this well and consistently. So we had to split our samples across Sanger sequencing, pyro sequencing, capillary electrophoresis, real-time PCR, and sometimes we even had to develop a high-resolution MELT curve analysis for screening for low frequency mutations. And you can imagine the challenges this would create for lab and the clinical teams, where you have to maintain multiple platforms. The results will come out piecemeal, not at the same time. Thankfully, the availability of commercial production scale NGS systems, next generation sequencing systems, allowed us to do all of these in one platform. And that's kind of what we are using now. For just as a brief introduction to next generation sequencing approach, because it could mean many different things to many different people. Our goal, again, is to identify clinically significant genomic alterations. And there are many different flavors of NGS. One can look the most popular being the targeted sequencing, where we can identify the relevant genes for that particular tumor type or clinical indication and develop a targeted panel looking specifically at these different regions of the gene. So these larger boxes are exons, where the coding sequences are, and in between these narrower boxes are the introns, where these are the non-coding sequencing. They can still be very important clinically. But the targeted sequencing is one approach. That's the approach we use for many of our patients. We have an 81 gene and leukemia assay, where we do a high depth sequencing and achieve a 2.5 to 5% analytical sensitivity. There are other approaches. If you go beyond each individual gene or limited number of genes, we can look at all of these genes. An example using exome sequencing, around 45 MB, you can see how the number of the footprint of the panel becomes more, and your sequencing needs increase. We can also do the whole genome sequencing, meaning sequence introns, exons, and everything. And there, the size of each panel or footprint becomes much bigger, and there is a trade-off. So when you sequence broadly, you cannot sequence as deep, and therefore the coverage depth may go down. There is also a lot of interest in shallow whole genome sequencing for structural variation. And here, the sequencing depth can be 0.5x to 5x, so very low. Again, different applications call for different types of design, and this is what different NGS panels do, and that's where the laboratory innovations come into picture. If you look at the taste platform, as I mentioned, we can do whole genome sequencing. There are multiple different approaches that you can take. At the DNA level, you can do whole genome, mate pair, amplicon dip sequencing, as I showed earlier. We also can do the RNA sequencing. And the goal for all of this analysis after the information is generated to the sequencers is to identify different types of genetic changes, such as substitutions, such as the ones shown in these genes here, small insertion deletions, clonality testing, and so forth. So again, this is something that's very important when we design a panel or come up with a solution to know exactly what we are looking for with what clinical application, so that we can go back and identify the right platform, the right panel, the right approach to do so. So beginning with an end in mind really applies very well here to make sure that we develop an application that's really grounded in the clinical utility. So with that in mind, this is our panel here at MD Anderson Cancer Center. It's a custom design panel, and it does include a variety of these different functional classes of mutations, including the kinases, transcription factors, spliceosomes, cohesins, and so forth. So each gene and each one of those regions has been really carefully selected so that it becomes a high yield information. It's not comprehensive because it's only 81 genes, but it is high yield and therefore operationally and commercially sustainable. If you look at the same content in a different manner, you can now have the applications which are for different tumor types. So this is again something very important to keep in mind when we design some of these tools, that the indications, clinical indications, and this is primarily for bone marrow-based presentations, myeloid and some lymphoid presentations. When the patients present, we may not know the diagnosis. So we do cover indications from cytopenia to cytosis and everything in between in the bone marrow-based disorder. So this is another way of looking at this information. Again, it has to be based on clinical applications. So we had that panel working nicely, and we still have it in production. We may be updating that to include some of the newer content. But what we have seen is that having a comprehensive panel or high yield panel alone is not sufficient. As we move from having this biomarkers such as IDH1 and IDH2 in discovery phase, late in 2008, 2009, we developed Sanger assays, high resolution MELCO, followed by Sanger confirmation, and eventually NGS. The circle number in the circle shows the turnaround time. During this phase, we really had to develop a assay with the turnaround time, which was useful for something that was not going to be used immediately, but for future prognostication as a prognostic marker. Come 2014, now we have IDH inhibitors, and there, for clinical trials, and these are some of my colleagues here at MD Anderson, Dr. DiNardo and others, who really revolutionized the field through these clinical trials using IDH1 mutated, IDH1 targeted therapies. And there, the turnaround time needs accelerated. We needed to turn this around very quickly, and despite all the workflow enhancements, we could not bring it down more than 4.4 days using the technology we had available at that time. And in discussion with our leukemia oncologists, what is their ideal method, ideal turnaround time? It's 2 days, right? It's unheard of. Can you do NGS? Can you do all of these mutations and still turn around in 2 days? Can you have your cake and eat it too? Apparently, yes, because that was the need. So we moved from the efficiency optimization phase to more turnaround time optimization phase. And as they say, the necessity is the mother of invention. It did lead to an invention. This is a paper that we published a few years ago. It does highlight a collaborative approach, an innovative approach of how we are able to now report the results from bone marrow collection to reporting within 48 hours using our 81 gene panel, but selectively extract information for 11 genes, including P53, as Dr. Rahul earlier pointed out. And so this information is again provided through this innovative bioinformatics workflow. There are elements here of the actual clinical workflow. I heard Dr. Srinidhi made a comment about the molecular lab getting samples from the flow lab the same day by 4 o'clock. These are all very important. I wouldn't go into too much details, but a successful clinical care delivery relies on this type of teamwork and internal communication, coordination, along with the innovation on bioinformatics side, where we are now not without interrupting the sequencing, actually intercepting the data for our clinical use. I'll be happy to talk about this at a later date with anybody who's interested. But this really led us to deliver this 11 gene information for diagnostic markers for our hematopathologists such as calreticulin, JAK2, MAPLE, as well as the information on the therapeutic targets, IDH1, IDH2, or predictive targets such as P53. Another aspect of the revised classifications and clinical need is actually the germline predisposition to hematologic neoplasms. Again, I will not go into the details, but this is an area which has gotten steady and an increasing recognition that if we were to eradicate the burden of hematologic neoplasms, it's also important to identify what are the inherent risks through germline identification of germline syndromes. You can see a number of entities defined by the alterations in DDX41, Ancardin 26, TARC mutations, and so forth. So to that effect, we again reach back into our panel, and some of the panel content was actually designed to cover it. So it's just highlighting here from our 81 genes, the information that's relevant for germline, such as DDX41 and Ancardin 26. We did set up a identification mechanism from our panel through bioinformatics approaches. So in the lower right-hand side, you can see the variant allele frequency plots for some of these germline alterations, where you can see how the DDX41 germline findings are clustered around 50%, right, or sometimes in 100% in case of RUNX1 germline alterations. So these are all likely germline shown in orange. As compared to that, the somatic mutations, they show a different distribution pattern of a heterozygous or subhomozygous pattern, such as in P53, with the loss of the other allele. So again, these bioinformatics approaches are very important. And in hematologic neoplasms in particular, where we are not able to get a germline sample, such as the skin culture fibroblast very easily, these are very important mechanisms to screen, to use some of these panels to screen for potential risk patients, along with the clinical history, which can trigger a direct confirmation testing. So all the combined approaches are useful, but through this, we can now identify patients who are actually who can benefit from the germline counseling and future prevention effort. So this is also a very important portion of modern genomic assay. So in summary, the DNA-based targeted panels, they are high yield, they have a range of genomic alterations and applications, and the analytical sensitivity that we currently offer at a baseline is 2.5 to 5%. Moving on to the second type of alteration, which is the fusions in AML. We know that there are many different types of fusions. So again, as a laboratory diagnosticians, we are faced with the challenge that there are some alterations which have very consistent, such as RUNX1 T1 alterations. The breakpoints are fairly consistent. There are alterations such as CBFB, MYH11, where although the partners are the same, their breakpoints may vary. So there are many different types of fusion transcripts through different fusion breakpoints. For genes like RARA, there are multiple partners. There are some very common ones, such as PML, but there are also other partners which can have diagnostic and prognostic implications. And then we have genes such as KMT2A, which just has so many different partners that it becomes very challenging to develop a specific assay using the conventional primer-based approach. So understanding and knowing the flavor of these types of fusions is very important. And that really drives the design of the solution. So here we are just showing very briefly the different platforms that we have or had at different points in time or planning to have. And you can just see that for fusion detection, you can take so many different approaches, from single gene fusion to multi-fusion to targeted multi-fusion to the entire genome sequencing. Again, it needs to be determined with what's really needed for the clinical application and then go from there. The conventional partner-specific approaches rely on knowing both the partners forward and reverse and having a TaqMan probe. The partner agnostic approach just needs the knowledge of one partner. So these are just broad categorization. I'll skip this in the interest of time because I see that we have less time than needed. Again, some examples of partner agnostic fusion detection by next generation sequencing. This can appear quite boring to some people or quite exciting to the others, depending on what side of the result interpretation you are. But after doing all of that complex wet bench work and bioinformatics analysis, we get this type of a readout where the what you are seeing here in gray are each of those sequencing reads. And bioinformatically, we can define the component of two different genes that constitute the read, and then we use other tools to make sure that these are aligned and there is sufficient evidence for it to be called. There is also internal quality control as non-fusion reads. But these are the approaches which are becoming common, which is the partner agnostic fusion detection, and especially for genes which have multiple fusion partners. And also as a scalable platform, because we know and we've seen that there are so many different fusions that we need to cover. So partner agnostic approaches can be very powerful. This is an example of our panel that we run in our lab here. And this is an example of how we combine the RNA approach and the DNA approach to identify fusions and mutations at baseline. It also provides and helps us to understand some of the different flavors of rearrangements. Again, there is a fascinating biology underneath these different alterations. And so the knowledge of this is very important as we bring in more platforms and more powerful tools. They really need to be designed to understand just in case of an MECOM rearrangement, the mechanism of EV1 overexpression can be through promoter hijacking or enhancer hijacking. And when you have this scenario, you may not find a fusion transcript because the fusion transcript, these types of fusions at the DNA level do not lead to a fusion that we conventionally detect. It leads to an enhancer or promoter hijacking. So these methods or these alterations are best detected through FISH, through DNA-based methods such as OGM, or through RNA overexpression, but not by chimeric fusion detection. And there are other mechanisms. So depending on the alterations, we do need to correlate between the DNA-based assay and the RNA-based assay. And this is something that we have seen, and I think this is an important caveat when we bring these platforms. So how about the high, the next version or iteration? Because we talked about the targeted panels, DNA and RNA. The next frontier is how about if we do everything, then we can catch anything that's there in terms of the fusion. So this approach is also becoming, it's gaining popularity. It's not available everywhere. This is an example from the MLL lab in Germany from Dr. Hefferlach's group. What they've done is they published their whole transcriptome sequencing data for AML and MDS patients and shown that you can actually detect a number of different novel fusions that's linked to the different prognostic groups in these patients. And this is very important as we come across these patients who we may not know enough in terms of their genomic makeup, for the tumor's genomic makeup. And we may be scratching our head as per why this patient is not responding or why this patient is an abnormal responder and so forth. But by understanding their full genomic makeup through whole transcriptome studies, we can also identify novel fusions, start to develop these novel networks, and in some cases even identify a targetable fusion that would really save the patient if you can come up with a targeted therapy. I recall a patient that I saw here in my practice earlier on, where the patient was going from one institute to the other with a bone marrow presentation that looked like a storage disorder. And obviously, it was a case that came on a Friday evening, and we were fortunate that we had some tools that pointed us that this could possibly be one of those alternate RARA translocations. We were able to perform additional studies and identify that indeed this was not a PML RARA, but it was one of the novel RARA fusions. We did publish that paper, but more importantly, the patient could get on a targeted therapy. and the patient is still alive and doing well. So that could be very rewarding examples from understanding and identifying the specific alterations. Similarly, for whole genome sequencing in AML, Dr. Eric Dunkowich's group from WashU have really shown this, and this is data from the real life prospective study, that within 3 to 4 days time, we can get the whole genome sequencing data, identify different karyotypic abnormalities, structural variants, and then really help identify patients with that could have a significant impact on these patients' clinical outcome. So these methods are being considered and are being implemented, and with the sequencers being becoming more powerful, the sequencing cost coming down, and the clinical utility being more established, these methods are likely to continue to expand in more clinical spaces. There are some other new players that have come in, such as the optical genome mapping. It's a DNA-based method. It's not a sequencing-based method. We essentially tag a unique a motif on the DNA, a 6-mer motif, and that really creates this pattern where it's almost like looking at a barcode. And if you can read a barcode, you can read OGM. But jokes aside, the pattern is very powerful, and so we are unlocking the secrets again, as Dr. Rahul mentioned, right, in his introduction. Is what is the biology telling you, right? Are you listening? Are you reading? So this is the pattern that's there. It's like deciphering one of those extraterrestrial signals and say, is there a pattern here? And indeed, there is a pattern in those 6-mer motifs, where if you can look for the reference sample versus the test sample, and if you find that this pattern is deleted, it means that that portion of the genome is deleted, and you can call a deletion, array expansion, and so on and so forth. Translocation, when you find 2 different patterns inverted. Again, this require a heavily computationally based methods to do this. Dr. Gulin Tang in our group here has done amazing work in bringing this platform up for clinical testing, which is what we've been using successfully in our cytogenetics lab for our patients. There are other examples of copy number alterations which are relevant for this. Again, we talk about more broad genomic alterations, such as copy number alterations, copy neutral, where microarrays, whole genome sequencing, and others can be very powerful. So when you combine these newer genomic platforms, this is a paper that Dr. Dunkavage and we published in Blood, along with the ICC classification. And so I'll urge the audience to read through this, but it kind of highlights the different applications, their pros and cons, what type of alterations we can target, and what different diagnostic follow-up applications. It provides a nice framework, but again, the final selection and application depends on your individual scenario. So in the last few minutes, I'd like to touch upon a very important and emerging area in genomics, which is the MRD monitoring. Again, the challenge has been in AML in particular, that we were able to put these patients in remission or partial remissions, but many of them or majority of them would relapse. And as we understood more the biology and the dynamics of these different clones, it's becoming very clear and apparent that the measurable residual disease or the residual disease per se is a key factor. So if we develop effective therapies to eradicate the disease up front, these patients develop a more favorable outcome. And overall, historically, the RT-qPCR for translocation has been a mainstay, but it's not widely available for low prevalence fusions and uncommon variants. That's one of the challenge. And then also there is more and more need for standardized approaches for individual markers and a panel of biomarkers. So that's what we are focusing here. This is an example from Dr. Andrew Wei's group from Australia. Their KMT2A MRD monitoring assay, they do cover several different partners on this translocation. This is a targeted fusion assay, so it does not cover all KMT2A translocation. It does cover some common ones, And the data really shows here that the patients who really have a MRD negativity achieved, right, their relapse-free survival is significantly better than the patients who still have an MRD positivity after the treatment. So again, this just shows the need for us to understand, identify the MRD, and then go after it. The challenge again with the KMT2A is the number of different partners, and we cannot really have a multiplexing and full validation in the clinical scale for this type of multiplexing. So we are looking at a method which is a partner agnostic, and in that method, we hopefully will be able to share some data in future. But our method includes identifying low-level KMT2A transcripts irrespective of the partner, and we are excited about what that could show us. NPM1, again, is an example where this is not a stranger to anybody who does the work in AML. And this is, again, just one of those recent papers that now clearly shows the time points at which this becomes important, like what cycle number. It's important to look for what blood sample types are important. And so this, again, translates into a very specific clinical goal that when we should be testing for MRD, when we should be testing blood versus bone marrow, and what are the desired time points that we should achieve. For NPM1, a lot of the historical studies had looked at quantitative RT-PCR using the RNA-based method, and this could have some challenges. We have implemented a DNA-based method in our laboratory here very recently, where we are able to look at 10 to the minus 5 or 5 times 10 to the minus 5 level of sensitivity. And as with any other laboratory method, when you look for two different targets, DNA versus RNA, you could have some discrepant results based on the biology, sampling, and technical issues. That needs to be kept in mind. But irrespective, I think either one of those methods does provide a good starting point with appropriate validation for NPM1 example. This is just an example from one of our raw data here. We are able to show that this is the mutation and 4 base pair, and we had 10 molecules, right, out of 10 to the minus 5, which is amazing level of sensitivity when you consider MRD. And to the extent that we have introduced in our reporting schema a scale conversion table, because we looked at this MRD in terms of 5%, 1%. And when you go from there to 2-3 log below, we now provide this so that our providers can understand that this 10 to the minus 5 is actually 0.001%, right? So how they can compare the fold decrease and so forth. So this is a work in progress, but we're quite excited to offer this to our patients. Similarly, we have a FLT3 assay that we offer to our patients here at the same level of sensitivity. And from the for the molecular diagnosticians in the audience and for our leukemia oncologists, you can appreciate the fact that when we used to do the capillary electrophoresis-based detection, these smaller peaks or blips were very difficult to call. You can see the baseline here on the left-hand side on the right panel, noise, and then you have all these blips. Are these mutations? Is this really a or a non-specific noise? When now we do NGS, which is shown up top here, you can clearly identify a lot of these with specific variant coverage. So it's becoming very clear to see that there are multiple clones sometimes to begin with, and the relapse is not really a new clone, but it's just a clone that survived the initial therapy. So we're understanding a whole lot about the biology as well, and relapses. And lastly, I think it's very important that after we treat these patients with targeted inhibitors, there is a cat and mouse game happening. There are FLT3 mutations that can lead to inherent resistance or acquired resistance. Similarly, IDH1 second site mutations are emerging. Similarly, MEN1 mutations are emerging in response to menin inhibitors. So this is where our challenge begins all over again, that we are now chasing a more potent and a more elusive enemy than we had before at the baseline. Now, this particular clone has seen the drug and has developed a resistance mechanism. So our challenge now is how do you develop a strategy that you're not only monitoring for response, but you're also monitoring for or identifying any new resistance that comes up so you can stem early. So this is another exciting component. There are some other components in our strategy for post-transplant. I'll skip this in the interest of time. In our panel, we do include several of these unique SNP markers where we can perform and identify transplant failures while doing the mutation testing. So again, there is a lot of room and scope for innovation. And lastly, I would be amiss if I didn't mention that our strategy to address AML not only includes the AML after it occurs, but it also to prevent it from occurring or mitigating the risk in a high-risk patient. So we recently, the studies have recently shown that the clonal hematopoiesis have increased risk of AML. So in our strategy here at MD Anderson, we perform liquid biopsy and extensive mutation profiling for our solid tumor patients. What this slide shows here is that for both our MAP, which is the MD Anderson mutation precision panel, liquid biopsy and tissue version, we use a germline control to exclude the variants of germline origin. However, at the same time, since we use the PBMCs as the germline control, we identify alterations which lead to clonal hematopoiesis. And we have set up a mechanism where these clonal hematopoiesis patients are flagged for our leukemia prevention clinic review. And they are the ones who would then reach out and monitor these patients along with the cardiology team for other cardiovascular risk factors. So it does highlight the fact that although these are primarily solid tumor patients, our patients have primarily solid tumor, they may be high risk for future AML MDS development. And we try to identify the ones who are at higher risk and provide them that customized approach. So this again shows the multidisciplinary approach and the need for us to collaborate across the broader range. There are emerging applications and platforms, liquid biopsy in AML. We published a paper showing a proof of principle on how liquid biopsy can actually reduce the need for, can be potentially be useful for more frequent monitoring in plasma than genomic DNA, transcriptomics, methylation, single cell sequencing. So this is just again the beginning. There is a lot more to come in this space in terms of the AML genomics. And so with that, my summary slide, I think I've been summarizing this all along. So I'll stop here to allow for more questions. But again, for us, molecular biomarkers provide significant clinical information, diagnostic, prognostic, and predictive. The genomic testing needs are unique for pretreatment versus follow-up. We do require a comprehensive genomic testing using multiple platforms, and a combination of DNA RNA based approach is useful based on the genomic alterations that are detected in the patient. And last but not least, the genomic platforms are rapidly evolving, and I keep emphasizing this multidisciplinary approach so that the laboratory teams can get the support they need to develop the platforms, and then they can support the clinical teams in helping the patient. So it becomes that mutually beneficial or relationship where one cannot exist without the other. And I think this is again the need for the hour, which is the multidisciplinary approach and looking forward, thinking ahead, and making sure that some of these resources are provided in a timely manner so that tools can be developed which can further feed into the clinical care. So with that, I would stop here. Thank you all for your attention and this opportunity. And it's been my honor and a pleasure to be interacting with the group here. Thank you. So Dr. Srinidhi, I believe I have left 8 minutes for question now.
Yeah. So I think the list of questions which I sent you, most of it is anyways answered, and we will look out for any questions in the chat box. But then, so I remember when I heard you for the first time in Mumbai, so we kind of little joke that you have a 24-hour lab because, your TAT is 2 days and you pick out the mutations even before the sequencing is complete. So that was something which I want to highlight over here, and you will be glad to know that there are close to, in fact, 200 plus people who are listening to you right now.
Thank you.
So do you have a 24-hour lab, molecular diagnostic lab where?
Oh, for us?
Yeah.
No, we don't. We don't actually. We don't have a 24-hour lab. Our lab is it's essentially from 7 a.m. to around 7 to 8 p.m. and 5 days a week, full staffing. So we don't have any overnight shift, and we have limited staffing over the weekend. So again, that's what I mentioned earlier, that a lot of this also requires the collaboration. So one thing we did as part of that workflow optimization is we identified, I mean, the goal was to minimize any downtime. So from sample coming into the lab, and even before that, we monitor the sample as soon as it's acquired in the bone marrow aspiration clinic. So we had a recent initiative where we identified that up to 5% of our samples may be coming the next day because of the courier services and so forth. So we worked with the bone marrow aspiration clinic. So now 100% of our samples are received the same day, right? So because the turnaround time starts from the sample being acquired, right? Not when the lab receives it. And that's where the patient has donated or the sample's been collected. And so from there on, it starts, and we make sure that the sample gets extracted overnight, and somebody comes in early in the morning to perform the OD concentration and all, and hand the sample over to the sequencing team. And so that happens in the day. So just by switching the shift from 2 hours earlier in the day, we were able to shave off an extra day, because otherwise it would just wait for another day and so forth. And same thing, our late shift in the day leaves 2 hours late, right? I mean, they start 2 hours late and leave 2 hours late, but they are able to load the sequencer the same day. And then the next morning, the supervisor would come 1 hour early and to initiate the analysis and so forth. So these little tweaks here and there, they make a huge difference. And so that on top of this, so if you read the paper, it does highlight this approach where how workflow alone saved 2 days, how informatics approach added saving of an extra day and so forth. So that's why I think when I was very encouraged to hear your comments that you mentioned that you work very closely with the flow lab and you have this active interaction going on. And that's really the key.
Right. So we have a question in the chat box, which from Dr. Shiruk, who is asking, what about conventional cytogenetics and karyotyping and diagnosis? Do you send only NGS or do you also do a karyotyping?
We do all. So we do conventional karyotyping at baseline for specific patients such as AML. We also do OGM, because that's OGM is a form of a very high resolution, right? Karyotyping, structural alterations detection, and then we also do DNA and RNA based targeted NGS. So it's all part of because they all identify different types of alterations, right? So that's how that's the baseline workup essentially.
And so what MRD strategy do you use? Do you use a blanket panel which you have for MRD, or do you do patient-specific MRD? Because when we talk about MRD in India, most patients can't afford that money.
Mhm.
So we are, kind of probably compelled to resort to patient-specific MRD. Like if somebody has an IDH1 R132, I would probably do a digital PCR and not an MRD NGS. Although I know so right now we don't have ivosidenib in India, but sooner or later, whenever we do, we will have to look for resistance mechanisms also. But then right now, the cost is the issue. So what do you do? And I'm sure you do a very big panel.
Yeah, no, actually we don't. So I agree with your comments that I think I showed in one of my slides that the goal for MRD is quite different, right? So the goal for MRD is to find what's there, not really to fish for everything again. So at the baseline, we look for everything. Once we find that these are the specific markers there, then we go and look for them. So the common ones like fusions, we have single gene RT-PCR assays like inversion 16, PML-RARA, and so on and so forth. It's easy enough. They are single gene. You can get 10 to the minus 5, right, easily on those RNA-based approach. So they're taken care of. And if you can visualize that pie that I was showing for different genomic alterations, the next big piece in the pie is NPM1, right? So if you address the fusions and NPM1 and then FLT3, you address already 50 to 60% of the patients. Then there is a long tail of IDH1, IDH2. What are the other markers? I mean, there is literature that is still emerging. We know that the DTA mutations are not contributory, right? At least in some patient population and all. So we do intend to develop a mini panel that's focused on MRD resistance, right, and so forth. we don't have it yet. It's a work in progress. So right now our MRD portfolio includes the translocations. It's essentially single gene translocations, NPM1, FLT3 ITD, and so that will cover, because you're absolutely right. The cost is important, the stewardship, right, of this is important. Just the fact that you could do a fancy multi-gene NGS is not the reason to do it. I think it needs to be tailored to what the patient needs, what is the clinical application, and how it will benefit, right, and how it can be sustainable. And so I think it can only be sustainable if it is cost efficient and if it contributes to the patient care. One of the trade-offs that comes for the labs is if you try to develop a big panel, it's going to come at the cost of sensitivity, right? So there is that sweet spot where you don't want to make a very big panel, you want to make just enough size so that you can still go deeper, right? And there is always a trade-off. Do you develop 10 different single gene assays versus one mini panel that can do 10 genes well? So there are all these, unfortunately, there is no easy answers, right? But there is definitely there are definitely multiple options, and I think the option will depend on your practice setting and what is acceptable, right, as the clinical team. So I would always so we have a wonderful fellowship program here, and we have some talented fellows that come through the program. We always share that as pathologists, right, as molecular diagnosticians, our role is to become a solution provider and not just a service provider. You can provide a service, you can sign out a case, you can perform testing, but you need to understand the problem first, right? What is our clinical team needs, what our patient needs, and then come up with a solution, not just, and then you can continue to provide that solution as a service. So that's the kind of the mindset, but it requires you to engage directly with the clinical oncologist, see what their challenges are, right? See what our patients need, what their limitations are. So I agree with you 100%. I think your approach of being a good steward and coming up with a cost-effective and yet very sensitive method is really needed. Yeah, thank you.
So now I would go to the question what Rahul sir asked about, is NRAS the new TP53? Because for us, NRAS is like a devil. I mean, it haunts us at night because people are relapsing after 2 years of transplant, only with an NRAS mutation, especially core binding factor. And we don't know, we just don't know what to do because um, just pre-transplant or, just like 2 months before the FCM MRD is negative, the NGS MRD is negative, but suddenly the patient comes back with a relapse and these, and we just saw that, in the last consecutive probably 6 to 7 cases that it is NRAS. So now when we are faced with an NGS MRD which shows NRAS at 0.1%, we are compelled that, should we act? So the clinicians are kind of confused. Should we act on it? What should we do? So what's your take?
Yeah, no, I think that's a great question, and I think that keeps lot of people awake at night, and not just in leukemia. We do broadly genomic testing for leukemia, solid tumors, and all of the groups here. And NRAS, I mean RAS, right? And RASopathies are really the culprit, and they're really the challenge across the board. If you look at the lung cancers, right, colon and others, so there is definitely a need. And NIH here, NCI has launched an initiative about KRAS, right, and RAS related therapies and all. So they're definitely needed. We unfortunately, again, as I mentioned, we have not had a huge number of single cell sequencing studies to understand the relationship of NRAS clones, how they evolve. We have done bulk sequencing studies where we take an entire DNA and shown that NRAS is a subclone. Oftentimes, and this may be your experience as well, the NRAS clones are subclones. And then they emerge, right? So we don't know if you look at the three-dimensional topography, is this clone in isolation? Is it hiding? Is it going to come out, right? So if you consider the FLT3 and P53 to be the Duryodhans and Dusashans, right, of AML, NRAS may be the Shakuni, right, who's lurking behind the background and then trying to sort of instigate things, promote the pathways, right, and then creating more mutations. And when it may never come in the limelight, right, because it's got other players in the front, but it's the one that. So it's and personally, I don't understand the biology enough to answer your question specifically, but NRAS does remain a challenge across the board, and that's one of our future endeavors to develop more sensitive method for RAS mutations, given the challenge that you described.
And also, we are faced with a challenge that, in a mixed phenotype acute leukemia. So, although it sounds very experimental, but then we did it once, and one time point of that patient's disease, that post-transplant, he was only TP53 mutated, karyotypically normal. And we sorted the cells, myeloid and T, and we performed the MRD assay separately because there was a 0.1% TP53 lurking. So,
Mm.
what is your take on that 0.1% of TP53, almost more than a year post-transplant?
Yeah, and I think that's a great question and a very challenging scenario. The way we approach MRD is generally speaking for new findings or for scenarios or situations where there is no precedent or a guideline. Um, we generally don't act on a single data point unless it's so high, right? So, for example, if it was like 30% and then you had some other morphologic support and so forth, you could consider that as a relapse. But if it's a 0.1%, right, is that good enough control on the disease, right? That is going to stay at 0.1%. So the way we approach here is you can increase the frequency of monitoring, meaning that if you were calling the patients back every 6 months, maybe you can call the patient back sooner and see where that clone is going. If it is staying at 0.1%, right? Again, we don't understand enough. And depending on your goal and aggressiveness, you could go after it, right? But then the question would be, is it going to create more side effects of that additional intensive therapy versus just monitoring and watching it? We know that P53, right, could be the clonal hematopoiesis. It could be that background dysplastic clone. So it would be useful to also correlate that with how the phenotype looks like, right, by flow cytometry. What is happening clinically? Are the counts stable and recovering? So the idea being that a single time point at low level is really not the trigger, right, for action. It's a trigger for action to monitor it more closely and then to catch any expansion, right? I mean, if you see that it's growing, then you know it's going to explode at some point. So that's the time when you intervene. And how you intervene, I'm not a clinician, so I would not venture into that very specialized territory. That's for Dr. Rahul and other experts to decide.
Yeah. So, and what is your take on the fancy techniques which are right now coming, spatial transcriptomics and fragmentomics and AML? Are they still elusive or are they there? Because I don't understand how spatial transcriptomics will happen on a bone marrow biopsy for the mere reason that we, at least in India, use acid decalcification and RNA. I'm sure, I don't know how will that work because it's going to degrade. So. Just this last question,
Yeah, no, I think you saved the toughest question for the last. I see that. So, no, I think these are fascinating. And so what we are right now under is what I consider is like the innovation cycle. So if you follow the innovation cycle, right, there is a new technology that comes in, it gets at traction, then it expands in application, and then another technology comes in and replace it, right? So that new technology becomes the new technology. So NGS was there about 12 years ago. It still hasn't reached the saturation. It still is in more of a maturation or growth phase. We are still, again, pardon the PCR analogy here, but that's what the if you look at the innovation cycle, it exactly looks like a sigmoidal curve, right? So in that sigmoidal curve analysis, the PCR or the transcriptomics or omics, right? Spatial transcriptomics, other methods, they are at that early nascent phase. They have to overcome these challenges of technical barriers, right? Like decalcification. Beyond the technical barrier, what is the interpretation barrier? Can we make the data interpretation easier? Can we find a specific clinical application? It's all nice and fancy to see, right? That you can do all of this, but then what does it mean for the patient? I personally, as a hematopathologist, also at heart, I see a lot of applications of something like this where we are not going to now need, I guess, to do multiple immunohistochemistry stains, right? Or to do 2, 3 different methods. We could potentially combine a lot of these and say, here's a subcortical niche of these blasts that have survived, but they are the ones who are carrying the NRAS mutation, right? They are the ones who have these abnormal signatures. So we can easily catch it. But those applications have to be developed, but the technical barriers have to be overcome first. So where a lot of these tumor microenvironment methods and others are happening is in non-decalcified tissues, including solid tumors and in lymphoma because of the sample type. And while bone marrows were ahead in molecular because ease of access, I think the need for decalcification is really something that's challenging there. So, well, you can't always win. So bone marrows have to come next after the tissue in this case. So.
Right. Right. So I think all the questions are done, and thank you so much. So it was a great overview of what trends are there in genomic testing, and right now India as a country, I think, is growing rapidly in terms of AML genomics, and I will definitely get on a call with you to have you on board as our mentor and advisor, because we are still a very baby lab, I would say, but then we have big dreams. So thank you so much for sparing time on an early morning. Thank you so much, sir.
Thank you. Thank you. Nice seeing you all. Thank you all.
Thank you, sir. I think we can stop recording.